There's actually quite a bit of debate about what the clinical definition of cancer cachexia is, but in its simplest definition, cachexia, in this case, cancer-induced body weight loss. You can have cachexia in other diseases, or in heart failure or renal failure, but it's basically tumor-induced metabolic derangement that leads to inflammation and often anorexia, which produces body weight loss.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Teresa Zimmers, Professor of Cell, Developmental, and Cancer Biology at Oregon Health and Science University School of Medicine in Portland, Oregon, about what nurses need to know about cancer cachexia. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome. Thanks so much for joining us today, Teresa.
Thank you so much for having me.
Wonderful. Well, to get started, can you tell us a little bit about how you became involved in the topic of cancer cachexia and what kind of research and other work that you've done in this field?
Yes, I'd be very happy to. And first, I should say I'm particularly excited to be here with the Oncology Nursing Podcast because maybe of all people involved in cancer, I think that nurses have been champions of the cause of cachexia the longest. And in fact, years ago, when I was looking at funding opportunities, it was the National Institute of Nursing Research. It was the only institute at that time that actually had cachexia among its strategic priorities. And I think that's probably due to the fact that nurses tend to consider the whole person and not just the disease, for example. But I've been actually studying cachexia for a really long time. I'm a PhD, not an MD, and I'm a PhD in nursing and molecular biology and genetics. So I became involved in research on this topic in graduate school. We were looking at functions of various newly identified members of a particular protein family. And one of these caused a really profound wasting syndrome in mice. And someone said, that looks like cachexia. And everyone in the lab said, what's cachexia? That person was a surgical oncologist, and his name is Lenny Coniaris. And we began working on the topic together. And we actually ended up getting married, and we've been working on cachexia for the past 30 years together. And since then, we've spent our time studying how the body responds to injury or illness and how this results in weight loss, including cancer, but also in different organ injuries and diseases. Through using a lot of mouse modeling and discovery work using patient samples, we've discovered a number of drivers of cachexia, and some of these have actually gone on to be targeted clinically in patients with cancer. So, we've tried to develop knowledge in this space, which is a very small field in general, growing now, but, just a sliver of all cancer research. It actually represents just a fraction of 1% of publications in all of cancer and a fraction of publications and clinical trials in cancer. So just a couple hundred interventional trials in cancer cachexia. But the topic is growing and the number of researchers are growing, in part because all of us who study cachexia have also necessarily had to be advocates for the topic. 3 of us co-founded a nonprofit called the Cancer Cachexia Society to bring awareness, education, and research in the topic. We've had 7 international conferences on this topic, including one next year in Torino, and we'd love to have nurses attend. And so the field is growing, and we're trying to expand to reach not only other researchers, but patients, caregivers, advocates, funding agencies, and of course, clinicians.
That's outstanding. And hopefully this podcast will serve to extend that reach, especially to our nurses that we know listen to the podcast frequently. So excited to talk about this topic with you today. Can you start also with just giving us a definition and overview of what is cancer cachexia? And also, how does that differ from sort of a similar term, anorexia?
There's actually quite a bit of debate about what the clinical definition of cancer cachexia is, but in its simplest definition, cachexia, in this case, cancer-induced body weight loss. You can have cachexia in other diseases, for in heart failure or renal failure, but it's basically tumor-induced metabolic derangement that leads to inflammation and often anorexia, which produces body weight loss. And this is due to these myriad effects of the tumor on the body or the host, from the brain to the liver to bone marrow hematopoiesis, and then specifically on the end organs the field tends to focus on. And what is obviously evident once you look at someone with severe cachexia, the fat and muscle wasting. And in muscle, it's both cardiac and skeletal muscle. And anorexia is often a component of cancer cachexia. In fact, some people call it cancer-induced anorexia cachexia syndrome, because the tumors produce factors that act on the hypothalamus and hindbrain to produce, among other things, anorexia, but not just anorexia, feelings of misery and hedonia, wanting to withdraw from social interactions, but definitely altered desire to eat and altered taste of food. But while it is absolutely true that eating less can accelerate cachexia and that eating can help slow cachexia, studies have shown that you cannot feed someone with cancer cachexia enough for them to maintain their body weight. So anorexia is an important component, but certainly not the whole story.
So can you go in a little bit more detail about the causes of cancer cachexia and maybe some more depth on the pathophysiologic processes behind it?
So the current model is that the tumors produce factors, and these can be small molecules, proteins, metabolites, microRNAs, exosomes, fractions of cells that interact with the host. And maybe, certain tumors are interacting directly with the nervous system. But maybe what seems to be a first response is that some of these factors can act on the central nervous system to dysregulate appetite and metabolism. Cancer causes activation of the hypothalamic pituitary adrenal axis. So you get an ongoing stress response. That often results in an elevated heart rate and can directly induce catabolism, particularly of adipose tissue. But the tumor and then the body in response to the tumor also produce factors that drive what is ultimately a non-productive inflammatory response. You'll see that as an acute phase response. It's the low serum albumin, and in places where they look for it, high C-reactive protein. And those cytokines cause massive immune response, which is, as I said, does not serve to fight the tumor, but instead is metabolically expensive. You also get proliferation and activation of innate immune cells like neutrophils. You'll see high neutrophil counts in patients, lower leukocyte counts, and this systemic inflammation diverts nutrition and resources from other tissues. And some of those factors will actually directly act on fat and muscle to cause catabolism. So you can take some of these tumor-derived factors and put them on fat and muscle and cells in culture and see that they drive wasting of those individual cell types.
Let's talk now a little bit about the risk factors. Are there risk factors for a patient to develop cachexia? And similarly, are there any early warning signs that nurses can watch for these patients?
Cachexia is most common, where it's been examined in patients with upper GI cancers. You could think of those as risk factors for cachexia. So that includes, of course, head and neck cancer, esophageal, gastric, pancreatic, liver and biliary cancers. It's also found to be very prevalent among patients with any kind of metastatic cancer and very frequent in patients who are hospitalized for their cancer. But beyond that, about half of patients with non-small cell lung cancer also experience cachexia. I've been told by oncologists that cachexia is frequent in patients with certain rare cancers like ocular melanoma, small cell lung cancers. But generally speaking, cachexia is under-recognized. People have in their minds this picture of someone who's sort of end-stage cachexia that's emaciated. And in fact, most patients, or many patients in the U.S. at least, arrive with a cachexia diagnosis and may be overweight or even indeed obese. But that does not mean that they don't have cachexia. That's actually very frequent in patients with overweight and obesity. As well, people tend to think that there's no cachexia in, say, for example, ovarian cancer. And in fact, when people look carefully, it turns out that cachexia is very frequent in ovarian cancer. And similarly, in patients with hematopoietic malignancies like acute myeloid leukemia or multiple myeloma. It's estimated that 80% of people with end-stage cancer have cachexia, and estimated that about a third of patients with cancer actually die of the cachexia. So it's something that we need to be aware of as treatments begin to be developed. Cachexia is probably also underappreciated in pediatric cancer. In fact, that term is not currently used in children with cancer. They tend to use terms like failure to thrive or failure to grow. But we're finding that some of the biomarkers seem to be similar between children and adults, and maybe that is cachexia in kids can be addressed. And as far as what's been found for risk factors, although men tend to lose more muscle than women do, and men seem to have a higher rate of cachexia, higher rate of weight loss. Anybody can get cachexia. Other risk factors seem to include diabetes and smoking.
It's really interesting. Thank you for sharing that. So, what are some screening methods that nurses or other health professionals can use to help assess and identify cachexia or the risk for cachexia? And are there any specific tools that you would recommend?
I just want to say again that I'm a PhD, so I don't take care of patients. I have tremendous respect for our nurses who take care of patients, and all of them have their preferred screening tools. There is no single accepted or mandated approach to diagnosing or treating someone with cancer cachexia. And I should say that I didn't mention a widely accepted definition for cancer cachexia in the field. A diagnostic criterion is weight loss of greater than 5% in the prior 6 months. And this is unintentional weight loss. So obviously, someone who is starving for some other reason or is on some kind of weight loss drug, for example, or 2% weight loss or greater in anyone with low skeletal muscle index, so someone who meets the clinical definition for sarcopenia or has a BMI of less than 20. So those are the diagnostic criteria for cancer cachexia. That is not typically used when screening patients who come to the clinic. So what my colleagues use, for example, in the pancreas cancer clinic, is the malnutrition screening tool, the MST. Another tool that has been used in association studies with outcomes, that scores of which associate really strongly with cachexia and mortality in cancer, is the patient-generated subjective global assessment, or the PGSGA. You're probably familiar with this tool. It's two-sided. On one side, the patient answers questions about their health and their symptoms and their function. And on the other side, the provider, provides input. It turns out that patient page is actually highly associated with cachexia severity and outcomes in cancer. So from a research perspective, we find that tool really useful. Another tool that was developed was the CASCO, the CASCO. It incorporates aspects of body weight loss and lean body mass loss, questions about anorexia, parameters around inflammatory, immunologic, and metabolic disturbances, physical performance aspects, and quality of life. So as a tool, it can help identify patients who are pre-cachectic. It can stage the severity of cachexia and can be used to determine who might be at risk for hospitalizations after surgery. So as I said, there's not a specific consensus tool. And in fact, it's partly because there are very few cachexia-specific clinics around the world. There are a handful, and they're growing, but there's just no particular standard of care for screening at this point.
Thank you for sharing all those different options for tools, and we'll be sure to link to some additional information to those in our episode notes for our listeners. What are some management strategies to help either mitigate the impact of cachexia or to treat it? And maybe we start with pharmacologic strategies, and then we can also talk about some non-pharmacologic strategies.
Most providers who see patients with cancer cachexia use a combination approach. And what I think they start with is addressing the symptoms, particularly the symptoms that prevent someone having optimal nutrition. And so that might include drugs or interventions to increase appetite, to increase gut motility, to increase protein intake, and even psychological care in order to address symptoms of depression that might be affecting patients' ability or desire to eat. So virtually all of the providers I know take a holistic approach to the person with cachexia. As far as pharmacologic guidelines, the American Society of Clinical Oncology issued its first guidelines in 2020 or 2021. First ever. The Europeans were ahead of us on this. But those guidelines, which are evidence-based, and try to recommend interventions that show evidence of efficacy and low evidence of harm. Basically recommend nutritional consultation. They suggest a short course of a progesterone analog or a corticosteroid for patients to see if they will respond. Obviously, they can't keep them on corticosteroids for a long time. The guidelines were updated very recently based on 2 clinical trials to try a low dose of the antipsychotic medication olanzapine. So olanzapine is used in patients, for psychiatric indications, and those patients have a tendency to gain weight and ultimately develop metabolic syndrome. So it was actually tried for patients with cancer cachexia, and the outcomes of those studies suggest that patients ate more and had fewer adverse events and maintained body weight on treatment. So I hear anecdotally that there's actually quite a lot of use or a lot of prescribing of olanzapine, at least in the United States and Canada. Interestingly, I was speaking to a patient, and patients tend to get a lot of medications in their cancer treatment. And she looked at this one, olanzapine, didn't quite know what it was for, looked it up, saw it was an antipsychotic. And she said, well, I'm not psychotic. I'm not going to take this medication. So clearly there needs to be some communication along with that. The Europeans tend to use a combination approach, maximizing nutrition. They recommend exercise, and they often provide some sort of anti-inflammatory. And this was actually tested in a large study called MENOC. So it's widely believed that you do need a combination approach to address food intake, movement, and something to address this chronic inflammation.
Well, that's interesting, especially when you were talking about olanzapine. I'm sure many oncology nurses are familiar with that drug, as it is becoming somewhat standard to be given as part of our anti-emetic regimen for those really highly emetogenic chemotherapies. And so, as you mentioned, educating our patients about understanding what drugs are actually approved for through the FDA versus how they are sometimes applied in other settings, that it's a very important education point so that patients understand the context and that we're not trying to secretly treat them for psychosis, but it has other impacts. So I think it's really interesting, the connection there between not only helping to treat or prevent nausea and vomiting with chemotherapy, but then also potentially to help mitigate the effects of cachexia as well. So when we think about cachexia, we know that this is a significant source of morbidity for our patients with cancer, and effective treatment would be ideal. Are there any emerging treatments for cachexia, or are there any currently active clinical trials that you can highlight that are showing promise for future treatments?
Yeah, absolutely. I just came from the Society of Cachexia and Wasting Diseases meeting in Washington, D.C., and it was really exciting how much involvement there is in the field from pharmaceutical companies and biotech now. There's a molecule, GDF15, growth differentiation factor 15. You can think of it as the misery molecule. So this is produced actually whenever there is cellular stress or injury. And so high levels of GDF15 associate to, for example, cardiovascular events, preterm labor, cancer and cancer cachexia. So it's non-specific, but highly sensitive marker of cell stress. It turns out that GDF15, although it's expressed in the body, actually signals in the brain some very specific receptor called GFRAL. And it appears that the major effect of that is to produce anorexia. So you think of it as the misery hormone. So the signal your body produces when you're sick to tell you that, it's time to stop moving around and looking for food. Instead, it's time to hide and heal. So I think that this was an evolutionary adaptation to protect us from predators or to protect us from infecting our families during evolutionary times. It's quite interesting that if you inhibit that, at least in mice, or if you delete it entirely, so you have knockout mice, that those mice seem to be pretty normal. And in fact, there are people who don't have GDF15 and they seem to be normal. But if you block it acutely, at least in mice with cancer, they regain their body weight. So you can prevent body weight loss and regain body weight. The mice eat more, they're more functional, and they save their muscle. So there was recently a clinical trial of an antibody that was developed by Pfizer called ponsegromab, and they enrolled patients who had pretty late stage disease. patients who would not be predicted to gain weight. And in fact, in this phase 2 study, there seemed to be a dose-dependent response of increase in body weight with patients who received the antibody. So obviously, a lot more trials need to be done. A big study needs to be done in specific cancers. But that is a positive indication that there might be down the road some target-specific drugs for blocking weight loss in cancer. There's a lot of difficulty right now about defining cachexia, defining what are appropriate endpoints, determining what the FDA would find an appropriate endpoint for approval. But there is at least a biological signal there that targeting GDF15 might be helpful in patients who have cachexia. And in addition to that, there are actually quite a flurry of trials targeting other mechanisms for things as different as targeting other cytokines to synthetic cannabinoids that don't have an effect on the brain, but actually have an effect on the periphery and other approaches. So I think there's reason for optimism in the future. And I think that we're at the inflection point of an exponential growth curve in understanding and treating cancer cachexia. Unfortunately, at the moment, there is no approved therapy. I never mentioned anorexia, so a ghrelin mimetic that was trialed multiple times in the United States and never reached the primary endpoint, so never was approved here. It is actually approved in Japan and is used frequently. And I just heard from a colleague last week that he thinks it's a good drug and that some people do really well on it, but it's just not an option we have in the United States yet.
Well, as you said, sounds promising and exciting that we might be on the cusp of not only more research, but hopefully maybe some positive outcomes that lead to actual treatment options for patients who suffer with this. So very exciting to hear. One thing that we haven't talked about yet is just the knowledge that cachexia in our patients can be distressing to their caregivers, their family as well, not only the patients themselves. So what are some ways that you might recommend nurses or other healthcare professionals can support caregivers of patients who are suffering with cachexia?
Yeah, I think that's a great point. And I hear from family members all the time about how this is actually the most distressing part of their loved one's cancer journey because it's something so visible. And also, so much of our relationships happen over meals, right? And interactions over meals. And what I've heard time and time again is that telling someone that there is a word for this, cachexia, and explaining that it is the tumor, right? It's the cancer that's causing this appetite loss would have helped because there tends to be a lot of conflict over meals, a lot of guilt on sides when it comes to eating and trying to prepare meals that are appetizing for the person with cancer. And so hearing that word and understanding that this is part of this is a side effect of the cancer, a symptom of the cancer is helpful and empowering. And they want to hear actually that word cachexia, even though it's a strange word and it's hard to spell and hard to say, knowing that there's an entity on which they can focus, they feel is empowering. And so we've actually incorporated a lot of the patient voice and caregiver voice in all of the work that we do in the society and my own research. And it has been really helpful. They say what the things that are most concerning are their loss of independence, their loss of strength, the inability to carry their grandchildren. And so that shapes how we do our research. And so I think providing those family members and the person with cancer themselves, that terminology can be really helpful. And I think that given that many people come to our society and the Cancer Cachexia Network, which is a group of people who talk to each other through Facebook and other platforms. It was founded by Martin Cachexia, who's a patient advocate in the Cancer Cachexia Society. They all have oncologists. They've spoken to their oncologists and they still have all of these questions. And so I think, oncology nurses are really good at connecting those patients with social workers, dietitians, physical therapists, psychologists, people who can help them address all of those symptoms around their cachexia that can help them do better and feel better.
I think that's just so perfect what you said about essentially giving it a name, giving it visibility and giving it a name and help, I think, maybe breaking down some of those assumptions of like it just being a choice or a will or not having the will to eat. It's certainly not that. And as you mentioned, some of the guilt and other feelings that come associated with that, since food is such a part of culture, that I think it's just really great to hear you recommend that, just giving patients and their families sort of that clinical name for it, and that it is something beyond just, a patient's choice or willingness to eat, and that helping to connect them to those support networks would be a great resource for them.
Yeah, I appreciate you saying that. And actually, it brings to mind that we've heard more than once that some patients are actually really excited when they start to lose weight because it's hard to lose weight. And people find themselves losing weight for the first time. Some people, think of that as a positive. It's just in this particular context, it's not a positive, right? So that education, I think, also has to be provided.
So you mentioned a few, but are there any other resources about cachexia that either caregivers can use to support themselves or that they can share with their loved ones who are suffering with cachexia?
People are trying to develop materials in this space because it is a pretty barren field out there in terms of resources. So it's interesting that even in some languages, there isn't even a word for cachexia. So that's something that we've realized in our society. So the Cancer Cachexia Society, as I mentioned, is a nonprofit that we founded. We have an educational tab there and it links out to some resources, particularly those with other organizations. The American Society of Clinical Oncology has some educational materials for patients and for clinicians about cancer cachexia. The American Cancer Society has publications on nutrition and informational publications on cachexia, as does the National Cancer Institute. The cancer support community recently concluded a big effort to create an informational flyer about cancer cachexia that is available to use to converse with patients. And this was validated through patient interviews and focus groups. So this is a nice flyer, nice tool to start that conversation.
Outstanding. Well, we'll be sure to link as many of those in our episode notes as well, so that those are resources our listeners can review and tap into and hopefully find a place to use them in their clinical practice as well. Well, Teresa, thank you so much for joining us today. We're about at the end of our episode today, but we always like to wrap up our discussions with just a series of quick fire questions to help summarize some of the things that we've talked about. So to start that off, how do you think healthcare professionals can evaluate their hidden or implicit bias about cancer cachexia?
Yeah, I think that in the past, people viewed cachexia as just what people look like when they're about to die. In fact, we've encountered a lot of resistance in the field about whether or not this is a disease that with targetable mechanisms. And so I think viewing cachexia as a specific disease process that we can address is important. Also, it's important to recognize that patients who have overweight or obesity can also have cachexia. And so it's not simply that end stage emaciated patient, but it's something that, very often patients present with at the time of diagnosis, whatever they may look like externally.
What are some common misconceptions about cancer cachexia?
Again, that it can't happen in someone who's overweight and that it's due to a loss of food intake. That's certainly part of it. And we should certainly advocate for everyone to maximize their nutrition, but that is not going to be sufficient to block it.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think that we don't often think about how much the cachexia itself affects the cancer treatment outcomes. The presence of weight loss correlates with treatment toxicity. Chemotherapy is often dosed on body surface area. Patients who have very low muscle, for example, experience greater toxicities. And maybe we should be dosing based on lean muscle mass. Patients with cachexia have poor outcomes after surgery. And actually, patients with cachexia don't respond to immunotherapy, which of course has been transformative for cancer care. So treating cachexia may actually enable patients to respond better to all of their cancer interventions. And furthermore, at least data from the laboratory suggests that the wasting in cachexia may actually drive tumor growth and progression. So this is all part of a macro environment is how we refer to it, where we believe that if we can block the cachexia, we can improve quality of life and length of life in response to therapy for the patient, but we also may directly affect tumor growth and progression. So it should be looked at holistically and equally important to the tumor growth.
What additional training or education would you recommend for oncology nurses that are trying to stay current on this topic?
So this field is, on the scientific side, it's moving really fast. Review articles get written all the time. So I think it's possible to get up to date by reading a recent review article. I would love to see participation of oncology nurses at our conferences, which are in person or online. They're called the Cancer-Cachexia Conference. I said the 8th one will be in Turin, Italy next September. There's also, if you're interested in the bigger picture of cachexia and other diseases, there's a Society for Cachexia and Wasting Diseases annual conference. And, of course, clinical guidelines that get periodically refreshed by organizations such as the American Society of Clinical Oncology.
And finally, what are some additional resources for patients or other healthcare professionals who want to learn more?
I think we described the ones for healthcare professionals, but I just want to come back to the Cancer Cachexia Network. It's small, it's young, but Martin Kochansik is working really hard to make that a place where people can ask any question they want, and in sort of a not judgmental place, and people can share their experiences and in sort of a bi-directional way help shape and improve research and education around cancer cachexia. So that's Cancer Cachexia Network.
Wonderful. Well, Teresa, thank you again for your time today and sharing your expertise. Certainly a topic that, as you've mentioned, has not always received the attention that it deserves, but based on what we've talked about today, it sounds like that is going to be changing very soon. So thank you again. Do you have any final comments to share with our listeners?
Thank you for the opportunity to speak here. Oncology nurses are incredible. I think have an amazing capacity to help change care for cancer cachexia and understanding of patients as they go through this journey. So thank you so much for this opportunity. And we would really welcome participation from your members in any of our efforts.
Wonderful. Well, thank you so much.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.